Epilepsy is a very common term that we've all heard, but we might not have a clear picture about the scientific aspects and the newest technologies within the treatments. So today we have Dr. Nihal. He's a functional neurosurgeon and a consultant in epilepsy at Medical Trust Hospital, Ernakulam. Hi, doctor. Like I said, epilepsy is a very common term, but we are not much familiar about the scientific aspects. But what I wanted to ask is that what is the newest technologies or the newest ways of treatment in epilepsy?
Yeah, so epilepsy treatment has gone a long way. Like it was first in 1932 when a German psychiatrist he invented the EEG, what we use now for diagnosing epilepsy. So he was a psychiatrist. So mainly that in those period, the epilepsy was like treated by psychiatrists. It was treated as a mental disorder, not as an organic disorder. So from there onwards, it has gone a very a long way. We have got so many newer drugs. So the previous drugs which were in use had a lot of side effects and all that. So now we have very specific targeted drug therapy. We have advanced surgical options now, which was not prevalent. Like if you talk about like 20 years back, these were not so much in vogue. People did not have any knowledge about this. But now surgical aspects and many other newer advanced therapeutic neurostimulation, neuromodulation aspects of treatment have emerged.
Okay, when a person is seen with this kind of expressions, the first thought is about the medicines and the drugs that we have. But right now, we are getting familiar with the surgeries we have. So, what is the newest technologies regarding the surgeries? Because I think it is something that people are risking to, because not everyone is eligible for according to the criteria. So, what is it about the surgeries?
See, basically, about 30 to 40% of the epilepsy is drug refractory. So, what is drug refractory epilepsy is what we should understand. So, we have a international league against epilepsy, an organization which lays the standards for epilepsy. So, according to ILA, drug resistant epilepsy is a failure to control the seizures with two or more medications in appropriate doses for that individual. And the period of treatment is not under consideration. Initially, it was like we have to give drugs for 1 year, 2 years, and all that. But now it is that they have removed that criteria of the duration of treatment. So it is when the physician feels that the drugs are not effective, drugs are not producing the desired effect, then it can be termed as drug refractory. So why this change has been made is because there was a delay in referring the patients to surgery. So the doctors used to give medicines for for long periods, and there was an unusual delay in the referring these candidates for surgery. So this is the most important aspect, is what I feel, because early surgery, especially in children, is very much beneficial and has the best outcome.
Okay.
So that way, this the concept of drug refractory epilepsy has to be understood.
So, what is the time duration for the for having the idea of okay, we have to do the surgery right now? What is the time
Yeah.
duration?
So what exactly I'm trying to tell, there is no time. There is no specific time duration. What the clinician feels.
Okay.
So he feels that okay, it is. I have tried the maximum with the drugs. I have given for this individual whatever possible from my for its specific. So, for example, for one particular type of seizures, we have one set of medications.
Yeah.
So we have exhausted. So there are like first line, second line drugs. So we have used that in the appropriate dosages, and the clinician feels that it is not going to get controlled. So there is no point in further trying with keep on trying with more drugs, because the studies have shown that if there is failure with the best these two or three drugs, then there is very low chance that furthermore drug therapy may be able to control any seizures, and they have to be evaluated for surgery.
Okay. In your medical experience, have you ever been with a patient who have prolonged this drug treatment for a really long time that they couldn't, couldn't completely cure with the surgery?
Many patients. This is the most common problem which I have encountered. So even these children, which we could have got, I mean, could have got operated at a very young age. And see, epilepsy is for example, to give you an analogy, I mean, suppose two nations are at war, and one nation is bombarding the other. So epilepsy is like a bomb on that nation. So until that bombarding stops, there is not going to be any uh, improvement or any renovation or anything, rehabilitation in that region.
Yeah.
So exactly the same thing. Like if we first important thing is we have to stop the seizures
Okay.
in a child, or only then there is a cognition development and everything will occur in that time
Okay.
frame. So if the seizures keep on coming, then there is absolutely no chance for the global development of that child. So if you delay it, like for example, if you cross that milestone and the patient goes into his 20s, 30s, and all, then later surgery is not that beneficial because already enough damage has been made
Okay.
by the surgery. So we encounter a lot of patients on whom early surgery could have been done and they could have had led a better life. But that is exactly my point. There is no awareness about this, and that is why we are all here.
Yeah. So, doctor, for the chances of not having a successful surgery, is it a scale of how many times the seizure has occurred, or is it the age? Like as we age, is it the risks and chances of having it, a failure in the surgery, is it high?
So, the number of duration of the seizure is what is the most important factor. So, as the seizures duration increases, the chances that the surgery might, cure the patient of that disease, epilepsy, is keeps on decreasing. So, age is per se not a factor, but the duration of the surgery, the duration of the seizures, and the frequency of the seizures, and also the pathology. What exactly is the pathology? We have different pathologies. Okay, so for example, the tumor is they have a different type of set of outcomes. So developmental abnormalities, they have set of different outcomes. So there are many factors involved, not only, but this is one of the duration of seizures is one of the factors.
Just like every other surgeries, this epilepsy surgery will also have its risks and benefits. So, what do you think? Like, if you could point out certain risks and benefits, what would it be?
Yes, definitely. Epilepsy surgery is a brain surgery, and it has its own risks, like every other surgery. So you have the risk of bleeding. You will have the risk of infection. You have patient may develop fever. They may develop some new deficits like uh, temporarily some weakness of the body. Hmm. So these are all we call as that transient deficits, which recover over a period of time. So which are not permanent ones, but the risk chances are very low. So compared to the benefits, the risk chances are very low, and this should not be a hinder for going forward with the surgery because the benefits are like innumerable. So first of all, talking about the benefits, first of all is the seizure control in itself is the most vital thing. so which will provide some kind of confidence for the individual to lead a socially able life in the future. Once the seizure control happens, automatically other functions of the brain also improve over a period of time, like your cognition, your uh, mental capacity, memory, all this get boosted. Once that's what I told you, like once the seizure events stop, suddenly all these capacities which were suppressed by the seizures, they tend to get boost, and they improve over a period of time. So these are the major benefits. So seizure burden is the most important factor. Seizures per se are not life threatening, but they can lead to something called condition called as a status epilepticus, where you have continuous seizures,
Okay.
and then you don't recover from that seizure. So then you have a chance of uh, injuring yourselves during that episode, aspiration pneumonia and all that, which can lead to life threatening consequences. And we have something called a sudden death in epilepsy also, which is one of the life threatening you know effects of epilepsy. So these these are pose a threat to the life, which can be significantly, the risk of these happening significantly reduces with the epilepsy surgery. So it's not just the seizures per se, but these conditions are also prevented. So that way, and also even though you might not achieve 100% seizure control, but you can, with the drugs, you can have a socially able life. And the most important aspect of what epilepsy surgery gives you is the confidence to do anything, to go ahead in life and do the things you love. Like, for example, if you want to go out, there is so much stigma for that. What if I get a seizure? So he would be like so much introvert and will not go out in the public. So when you tell that person that now you are not going to get a seizure, it will take some time for him, but slowly he embraces that fact, and then he goes out into the society and starts, he gets to there are certain jobs like driving and heavy machinery where you wouldn't have gotten the job. So opportunities, employment opportunities, so education wise, friends, social life, and marriage for young women. So all these aspects, they are like the social factors. These are the most one of the beneficial aspects of achieving seizure freedom.
Yeah. Just like you mentioned before, people will have a lot of misconceptions about these surgeries. They might fear it because the surgery is performed in the head, right? Yeah, even I was a bit afraid when you said that, because a surgery for a normal person is not something that they take it
Exactly.
casually. So, what is the biggest myth that you have heard from a patient, maybe, about this surgery?
So, like I told, we in epilepsy surgery, we try to do an extensive counseling to the patient attenders. We tell about their it's always, epilepsy surgery is like a negotiation with the attenders. So we try to talk to them. What are their expectations? What are their problems? What they expect from the surgery? So that is most important. So some of them are like I told previously, they have that thing like, it is not going to. I mean, he's people think that epilepsy is mental disorder, or he's been possessed by the spirit and all that. So they are very apprehensive. Like I was in All India Institute where I got trained. So we used to do 1 hour counseling for the patients to convince them to, really accept this. But that 1 hour was very vital to them at that period of time. We never used to do counseling for any other cases as much as for epilepsy, because that is what I, like I told, the functional aspects. This have to be conveyed to the attenders. So yeah, it is always a very difficult job, but the to convince the patient, and but the rewards what they see later, that even they wouldn't have expected. So that is very rewarding both for the attenders as well as for the doctors when they see that the seizures have stopped and the patient is now getting back to the normal self. So that is a very good thing to do. But initially we have to explain to them, and we tend to, always go on the like more on the deficit side. We always tell them, because they you should not then convey to us that we have not explained to them
Hmm.
this worst case scenario. So we always tell them, but it has always, I mean, it has to be told in a way that we can encourage them to do, because it is very easy to get scared of such things and say that we don't want surgery. So that is what is important. As a surgeon, we should be encouraging the patients rather than, discourage, telling them that this can cause this and all that. So,
Yeah.
yeah.
So I think as a surgeon, your work doesn't start at the surgery table and it doesn't end at the surgery table. I think that is what I got to know from this, because from the moment they consult you, you have to convince them that surgery is safe, and then aftercare and everything is very important. So what are the newest techniques that has been involved in the epilepsy surgery which can be used to convince the patients that it is much safer?
Yeah. So once the patient is deemed as drug refractory, so we have something called a comprehensive evaluation. So patient first undergoes a video EEG where we record the seizures for over a period of 2 to 3 days. Then we record the events and we match those events in the computer, like where exactly is the seizure activity coming from. So once that is done, we do a special type of MRI called epilepsy protocol MRI. So this is done only in few centers, recognized epilepsy centers. It's different from a regular MRI because it picks up very minute changes which the regular MRI misses. So once MRI is done, we can do a PET scan. We have something called a MEG scan. MEG scan is relatively, I mean, it's there only in two places, one in AIMS and NIMHANS. So then we have something called a SPECT scan where we inject a dye into the patient once he starts getting a seizure,
Okay.
and then we see where the dye is localizing to. So this is still more advanced. So, and we have like functional MRI, what we do to find out where the, like if you're planning a surgery, where the area of his speech is. So the MRI shows like in a probable this area his speech may be involved, or this part his lower limb or upper limb muscles are in getting to be involved. So all this can be pre-surgically we can find out. So once this comprehensive evaluation is done, then only we have a meeting and we try to match all the investigations, and we say it is concordant or non-concordant. Everything is matching or not matching. So then if everything is pointing towards a single area, then only we go ahead with the surgical aspects. And this also gives confidence to the patient attenders and how they accept the surgery. So this is very convincing aspect. So this is what if it is concordant. What if it is not concordant? What if it is one area is showing, one investigation is showing something else, one investigation is not showing exact same area? What next? So then we have something called a stereo EEG. Stereo EEG is similar to a EEG. EEG, we put the electrodes on the scalp. So, but stereo EEG, we insert it inside the brain.
Okay.
The electrodes go inside a brain with by making small holes in the skull.
Okay.
So we do it with a stereotactic apparatus. We just mark where we want to put the electrodes. The electrodes will go inside the brain and they stay in your brain and they communicate outside just like a video EEG. And then we capture the seizures and we see where exactly seizures are coming from so that we can be more sure or more specific. So these are all some of the latest technologies which are available. So, like I said, epilepsy treatment has evolved so much.
Evolved a lot
Yeah.
actually, because when we hear that, it's actually a bit as if I was a patient sitting in front of you, I would be so much, we would be so nervous by hearing all this in the holes. But I think as a doctor, you really know how to convince people. So that is exactly why we have a lot of surgeries being performed. Like I think few years back, we wouldn't have been performing a lot of number of surgeries. So how do you think? How do we evaluate the growth of the treatment in epilepsy?
Yeah. So, like I said, with the advent of new technologies, uh, also there was a problem of the cost. So we used to get some of this. So, like if we are performing a video epilepsy surgery, we need certain materials. Like we have something called a electrocorticography grid, which we place on the brain during surgery for recording seizures intraoperatively. And then we have something called intraoperative neuromonitoring device. It's a neurophysiological device where we keep it in the brain. We just mark on the brain and find out where exactly like suppose the speech area, where exactly we do an awake surgery and we can ask the patient to speak and we stimulate that area, suddenly the patient stops speaking. So we exactly localize that this is the area of the brain which is responsible for speech. Similarly, for the movement, hand movement, leg movement, we place electrodes and we. So all this neurophysiological everything was not so easily available and accessible at maybe 5-10 years back as it is available now. So all this has helped a lot in the evolution of epilepsy surgery. And also these electrodes, like what I told, the SEEG electrodes, these are also very expensive for an Indian population. This is cost a lot. Each electrode is over a lakh of rupees. So we might have to put about 10 to 12 electrodes just for a diagnostic procedure. But now there are companies which are coming. There are in India. They are being manufactured rather than we have to export from outside. So that way the cost is coming down and it's becoming more accessible and feasible to the our population. So that way, it is a very positive step.
How much of an importance does brain mapping have in this epilepsy treatment?
Yeah. So brain mapping is a very revolutionary technique, which has been employed in not only epilepsy but also other neurosurgery, like tumors and all. So brain mapping essentially is a map of your brain which indicates where exactly is your like for example your speech area, like I mentioned before, or maybe your visual area, the part of the brain which is responsible for your eyesight. So we can intraoperatively, if the patient is awake, we keep the patient awake and we can stimulate that particular area. For example, now the lesion or the tumor is around that visual area. So we can show the patient intraoperatively in the OT. We can show them visuals or something to colors or visuals to read out. And as we stimulate the exact area, the patient will stop seeing for a moment. So this helps us to locate exactly where the visual cortex is. So that this part we have to preserve at all costs. So this is a very important aspect. So this gives us the surgeon the confidence that we can safely resect the epileptogenic area without causing any functional deficit.
Is it different for every brain? Like the vision, every.
Yes, that is why we do awake surgery, because although we know that everywhere, I mean, every brain has approximately, we know that this is the area where it is supposed to be, but actual area varies, although marginally, but it still varies and it still makes a lot of difference for that patient. So that is the whole aim of awake surgery, to find out exactly where the uh, area is, and not to make a guess, but because it really matters for that patient.
Yeah.
You can't take that risk.
Neurostimulation is a very important term in epilepsy treatment and basically all other treatments. So we have VNS, DBS, right? So we have a lot of treatments. So can you please brief about those different treatments?
So, till now, I have only talked about surgery aspect. This is the open surgery aspects. So, in some cases, what happens is we are not able to localize even after doing extensive investigations. We are not exactly able to tell that this is the area, this is one area where all the seizures is originating from. Okay, so it means that either it is not very well localized, or it can have multiple areas of origin. It can be bilateral onset. Okay, it can be multifocal, where the it's not a single foci where the seizures are originating from. So in these scenarios, what we cannot resect, we keep on resecting the each side. So we have something called neuro modulation or neurostimulation techniques in these difficult to treat epilepsy cases. So we have something called VNS, DBS, and RNS, which is not available in India, which is there in the US. So basically, VNS is a neurostimulation device. It's an implant. What we implant in the neck. There is a vagus nerve. So VNS is vagal nerve stimulation.
Okay.
So there is a vagus nerve in our neck. So which we put a coil something, and it is connected to a battery. So the battery is implanted into your chest wall, and the coil is around the vagus nerve. So it is coiled around the vagus nerve and gives electrical impulses to your vagus nerve, which retrogradely transmits to the brain. So it's not a brain surgery per se, but it is one of the neurostim modulation techniques used to treat epilepsy, where the seizure is being prevented from occurring. So the seizure episode, it is aborted by with the device. So there are various types of devices which I am not going to. And then you have something called the DBS. DBS is also it's classically been used for Parkinson's disease. So where the electrodes are not in the neck but actually into the brain, which stimulate the brain, and which uh, protect the brain from seizures. So it prevents seizures episodes. So there's also there's a battery which is implanted into your chest wall, and which gives currents, but it is directly connected to your brain. And RNS is another advanced option where the it is more expensive device which uh, detects the seizures and aborts the seizures. So the entire thing is placed inside your brain. Implant is placed like a chip. It is placed in your brain, which it detects, but it is not available as of yet in India. So maybe in the future.
So you have been a functional neurologist, neurosurgeon for last few 5 to 10 years. So what is the rewarding factors and also the challenging factors of your medical life?
Yeah, so challenging aspects I want to tell first because to convince the patient for surgery per se is the most challenging job, and to spread awareness and to say that you can be free of seizures, which the patient himself is not ready to believe, and you have to instill that confidence in the patient that yes, you can do it. I mean, you as a surgeon, you are just doing your job, but the most important onus is on the patient. He has to go through that procedure. So to convince him, to convince the attenders, to show that how much epilepsy surgery is going to benefit him, and to go ahead with that, that is the most challenging aspect.
And what is the most rewarding of aspect?
So rewarding aspect is for a surgeon is to see the patient lead a socially productive life. Like I still remember my first case which I operated. So even to this date, he's seizure free, and he sends me a text in the morning daily when I wake up, like a good morning text. So I mean, that just shows like how I was able to transform his life. So he remembers me like okay. So every once he comes for a follow up, so he's like so happy and is able to lead his life. And what else can a doctor ask for? This is the most you know biggest reward which you can get. But yeah, it is challenging.
Yes. So, doctor, what are the new breakthroughs in the treatments that we could see in the future in the epilepsy surgeries?
Yeah, so like I said, epilepsy surgery has evolved a lot, and it is still evolving. So we can expect a lot of advancements in the future. So I mentioned about neuromodulation, which was not available like 10 years back. So now regularly we are doing VNS and DBS for epilepsy patients. So newer, as research is going on, so newer drugs are becoming available, specific targeted drugs for that individual based on his genetic condition. Those are coming into the market, so which offers more targeted therapy for particular type of epilepsy. Then we have like diet plans specific to those types of epilepsy. And we also are experiencing advancements in the field of stem cells therapy, which is like for each individual what is the cause of his epilepsy. Based on that, we try to not provide symptomatic treatment, but you go to the cause and you try to rectify that cause. So which is still in the not in the market, but it is in experiment phase, and soon it is going to come in a big way. So then we can rather than one surgery for all, we can actually target that area which causes that abnormality, and we can prevent such mishappenings. Like for example, what in India right now, the most common cause of epilepsy is perinatal hypoxia during deliveries,
Okay.
which causes brain damage. So if certain factors can be identified, we can target that particular area in the childhood phase itself. And regarding this, so a lot of research, everything is going on. So probably we can expect this genetic therapy, gene therapy, and stem cell therapy, which will be a game changer in the uh, epilepsy treatment.
Yeah. So out of the all the talk conversations we had, I think what I can say is that the sooner the better for the surgery, right?
Yes.
Because the longer we delay, the chances of not having a successful surgery is high. So thank you, doctor, for sharing a widespread information about the surgeries and its every single detailing. It is fascinating. At the same time, it is informative. Thank you so much.
Thank you. Thank you so much.